morning from Miami Beach. This is Dr. John Bennett broadcasting UHA's China Neurosurgery Grand Rounds. And we, for the presentation of Leonardo Mastronardi on acoustic neuroma. But first, I'd like to introduce the translators. Welcome, Ben. Ben.
Hello, everyone.
Okay. Yeah, Ben's from Shanghai. He's translating into Chinese now in real time. And Takashi, how you doing, Takashi? Takashi, are you there?
I'm fine, thank you. Good evening.
Okay. Well, that was smooth. Okay, very good. Okay, Yuha, it's all yours.
Okay, I share the screen and you see my short introduction here. Okay, soon. Okay, we have welcome everybody. We have the honor to have Professor Luciano Mastronardi from Rome to speak this evening. He's very productive and critical skull-based neurosurgeon from Italy, Rome, has more than 35 years of experience in neurosurgery, has specialized at University of Sapienza, Rome, that was founded 1303. So this is one of the oldest universities, certainly in the world. He's professor and chairman at San Filippo Neri, and also professor, I don't see no text. He's also a clinical professor in Moscow at the Chekhnov Institute. If I remember right, please correct me. And then he has large experience in neurosurgery, has done more than 4,000 surgeries, and he is very famous in his skills in skull-based surgery. Has been teaching around the world with most prominent teachers on skull-based approaches. This is a big bunch of famous people who have been involved with him in different cadaver and life courses around the world. So he has a very impressive network around the world. And he has also published profusely, more than 500 publications, includes 10 books and more than 150 papers. And he's speaking now today on acoustic neurinomas. I have not done many acoustic neurinomas. My memory of the acoustic neurinomas when I was training as a resident were that it was a question of life at that time. And nowadays it has changed extremely much. So it is much more question of the preserving the facial nerve, because facial palsy may destroy the life of the patient, especially in young patients, but of course also in the old patients. It's very disturbing, cosmetically, but also otherwise. So please go ahead, Professor Luciano Mastronardi. We hear with interest your great lecture. Please go ahead.
Many thanks, Professor Ernest Niemi, for this very nice introduction. And I hope a very privilege for me to be here and to have this possibility to present my experience in Rome. In particular, the topic of my presentation is an update on vestibular schwannoma surgery according to the Fukushima teaching. Because I am very honored to be one of the pupils of Dr. Takanori Fukushima. And I would like to present a consideration on a consecutive serial of 260 cases. Some pictures of my city, please come as soon as possible according to this COVID pandemic, but when it's possible to reopen the borders, please come. As you know, it's one of the most beautiful cities in the world and many, many artistic point of view. This is my disclosure. At first, I would like to start with our current algorithm of treatment of vestibular schwannomas. When I have a diagnosis of vestibular schwannoma in a patient, I at first ask him or her which is his hearing or her hearing. And I can evaluate immediately the condition of patient and the volume of the tumor according to the cause classification. If we have the hearing preserved in a man or a woman with bad general condition, if this tumor is growing, I suggest radiotherapy. And this is probably one of the the few circumstances in which I suggest radiotherapy. Otherwise, if the conditions are quite good, I suggest to perform the microsurgical removal of tumor. If possible, of course, I will try to attempt the total or mid-total removal and follow up. In selected cases, in few cases where this is not possible, we obtain a subtotal removal and wait and scan. Normally, if this tumor regrow in very few cases anyway, I suggest surgery. In bad conditions of patients, in the meantime, probably I suggest radiotherapy. If the hearing is not preserved and the tumor is small, stable, and no symptoms, probably better to wait and scan. But if tumor is growing or symptomatic and the patient is good conditions, I always suggest surgery. If the tumor is large, no doubt surgery. When the tumor is growing, symptomatic, but the patient is in bad condition, I probably suggest, if the tumor is small, radiotherapy. In very few situations, I suggest radiotherapy, and mainly according to the general condition of the patient and the age, of course. But majority of cases, I suggest microsurgical removal. If patients are in the 8th decade of life, I mean, over 70, the situation can change according to the size of tumor. Of course, in large tumor, cost 3 or 4, I suggest microsurgery with judicious debulking. If there is no more growth or follow-up, we just wait and scan. But if tumor regrow, we can suggest radiotherapy. If the tumor is small and the symptoms or tumor growing, if good condition anyway, we suggest in small tumors the microsurgical removal. But if the condition is not so good on the general point of view, better probably to send him or her to radiotherapy. If small tumors have no symptoms, normally in old people, I suggest wait and scan. Now on the right side, I will start with a video. I hope that this video will not disturb you too much during my presentation. Anyway, this is the case we presented for Springer of a small acoustic neuroma with the attempt of hearing preservation. This video will go on during the presentation, and I continue to tell you our philosophy of treatment. There are 10 key points that we follow in vestibular schwannoma surgery. At first, the vestibular schwannoma surgery can be operated in different positions, but we normally use the Fukushima lateral position. We prefer this for my training in this position, so during these years. Then we do normally a keyhole opening and use the micro technique. The CSF aspiration at the beginning of the surgery is fundamental in order to obtain a decompression of the cerebellum. And this normally we do with a small incision of dura at the level of the lateral medullary system. Then we try to be clean, bloodless, and use the sharp dissection. I mean, if sometimes we can do blunt dissection, it depends on the situation. We try always to maintain the arachnoid plane and especially in large tumors, we always do a sufficient internal tumor debulking. And then we have to identify the positioning of the facial nerve. Usually we try with a monopolar stimulator. Then we try to elevate the capsule from the other nerves with the P-cut technique I will describe you later. Preserve any vessel and perforators, and most of all, preserve the petrosal vein. I don't believe that it's possible to coagulate it. Maybe better try to spare in every case. This is our series, updated to last month, 260 consecutive vestibular schwannomas. Majority of them are in between grade 3 and grade 4. The mean age is about 50 years, and the tumors in the youngsters seems to be larger than in the other ages. At the 6-month follow-up, our mean HB function is 93% HB1. I mean, 93% of patients have an HB1. Especially if the tumor is in ventral superior or in ventral inferior position. I had the worst results with nerve in ventral position. In my hands is the worst position for that. We try to improve it, of course, during the years, and now this is a cumulative series, of course. In the last period, the results are a little bit better. Hearing preservation was possible in 61% of cases, and in these cases, the diameter, maximum diameter was in average 2 centimeters. This is the summary of our results. As I told you before, the facial nerve function HB1 after 6 months was about more than 90% of cases, socially useful hearing in more than 50% of cases, with, of course, with a good preoperative hearing. The mean operating time is about 4 hours, and we use normally the retrosigmoid approach. The loss of blood was not so much. Usually it's very, very few, the lost blood. And cerebellar dysfunction was never observed, and transient vertigo in 1/5 of cases controlled with therapy. Instruments we use are several instruments. We have many scissors, many different kind of scissors, many knives, sharp knives, sickle knife, several micro curettes, several forceps dedicated to this surgery, then special knives like the Hitzelberger Meckelbein, shock door dissector. Then we have several tools that we use in operative surgery in all cases, the facial nerve intraoperative stimulation. Usually we use the monopolar stimulation with the Nimbus setting team. ABR, always when we attempt the hearing preservation. Then we use the Sonopet ultrasonic aspirator, both for the bone and for the soft tissues. The handheld laser fiber, I will show you later in the movie. And the flexible endoscope for the final check in the internally auditory canal. This is the position we use normally. Before, probably you saw in the video the positioning of the patient. The key of this position is the oblique position of the body. As you can see, the shoulder, the contralateral shoulder, is very close to the table and to the angle, to the corner of the table, close to the surgeon. And under the axillary, we put always a silicone pad. This allows to move the head in the best way with the 3 position of the head, flexed on the chin, a little bit rotated in the contralateral down, and the vertex down. The incision could be curved incision, or normally in the last cases, we use a straight incision, a little bit lazy curved incision. And we prepare in any case a fascia graft, and we harvest it for the final closure of the dura, much better than other substitute of the dura mater. The craniotomy we do is normally 3 centimeters squared, more or less 3.5 centimeters squared. In all cases, we expose the sigmoid sinus and transverse sinus and the angle in between, as you can see in this drawing of the Fukushima book. As told you before, the first step when we expose the dura is try to decompress the cerebellum. And we can do this by incision of the lateral medullary system and aspiration of the CSF. This is very useful because cerebellum immediately go down and you can open the dura in a safe way, and you don't need majority of time the compression with the spatula. The way we cut the dura is a little bit different from the standard classic incision. We use the reversal incision, you can see, in order to maintain the dura over the brain, over the cerebellum, and protect it. Maintaining the arachnoid plane is, as I told you before, a key point in order to avoid damage structures. And then, especially in small cases like this, we try immediately to localize the fascial nerve position. In this case, the fascial nerve was anterior, inferior, I mean ventral, inferior. And you can see this large vein, this large dorsal vein that we try always to spare, never coagulate. This is a paper we published some years ago, and describing the possible position of the fascial nerve in relation to the tumor. As you can see, in the majority of cases, half of cases, the tumor was anterior superior, the normal position of the fascial nerve. Was anterior inferior in 1/5 of cases, and anterior, I mean ventral, in 1/3 of cases. In that paper, we never observed at that time any dorsal case, but in our series of 260 cases, we had this dorsal and very bad position only in one case. It's very challenging. Normally, we use the nimbus monopolar stimulation, a different amperage in relation to the distance of the nerve. When we are far away from the possible position, I mean, of the capsule, especially in a big tumor, we start from 1 million pairs, sometimes we arrive to 5 million pairs in very large tumors. But on the nerve, we reduce a lot, maximum 0.5. Normally, we stimulate with 0.1 or less. We prefer to use the laser instead of the scissors when we have to cut the capsule of tumor. Mostly because this instrument allows you to be quite clean. I mean, it coagulates and cut at the same time, and it's very precise. And the penetration of the damage that this laser produces 10 times or more less than the bipolar. Then this Bouquet method is the Bouquet is the method that recognizes the position of the vestibular nerves. Of course, I'm speaking of small tumors, and try to open the tumor and separate it from other nerves. A key point, especially when especially when the tumor is located in the internal auditory canal in a large amount, we
Sonic
use
aspirator
the,
of the right side,
some
rated in
instruments
the
for
facial
opening
nerve
the
that is
internal auditory
located
canal,
anterior.
remove the tumor
Opening of the
inside.
internal
These
auditory
are
canal
the
is
limits
performed in the first step by means of tritium laser
electrical limits.
fiber that is used to coagulate dura mater of the posterior aspect of petrous bone in order to detach it and gaining access to the roof of the internal auditory meatus.
I don't know why it stopped at the movie. Sorry.
Are you okay there? Okay, no problem.
I'm okay, but just I would like to start again with this movie
Sonic
anyway,
aspirator is of the
just to show you how we use these instruments
Other
for opening the
structures.
internal auditory canal.
During
So
the stage, unroofing of the internal auditory canal is performed above dura mater of the auditory posterior aspect of petrous bone that is now coagulated to expose the tumor capsule formed to the cerebellopontine angle. After this stage, tumor resection is further performed in the internal auditory canal. Therefore, additional drilling of the roof of the internal auditory canal is performed, being careful not to damage superior and posterior semicircular canals located in the lateral portion. During this section of the internal auditory canal, low amplitude nerve stimulation is routinely used to detect the facial nerve. Tumor resection is further pursued by means of hooklets, curette, and microsurgical scissors. At the end of resection, a thin layer of tumor capsule is left. More recently, at the end of resection, we performed a short flexible endoscopic inspection of the internal auditory canal in order to detect possible tumoral residue located in the fundus. In conclusion, according to
then, as you can see, these instruments are very safe and very effective for the opening of internal auditory canal, and then we can remove the amount of tumor inside with several instruments like the curette, the iris, and other instruments. The laser too, including the laser. The elevation, the dissection elevation of capsule from brainstem and facial nerve and cochlear nerve at the level of meatus is probably the longest part of the procedure. Of course, also the risky, for especially for facial nerve palsy and in selected cases for the cochlear nerve function. And so we spent a long time during this phase of the procedure because we would like to avoid the deficits. This is normal. Then, as presented before, these endoscopically assisted microsurgeries could be very useful in order to avoid to leave inside the internal auditory canal some residue. And the simultaneous use of microscope and endoscope during the dissection of the CP angle tumors seems to be much better than endoscope alone, as someone probably suggested in the past. So microsurgery is the first step we use, as you can see, with several instruments, and then endoscope can assist it. But in my opinion, my hands cannot substitute the microsurgery. Sometimes during the drilling with the sonopet, we can have some irritation of the facial nerve and we move to drill, but this is very seldom, very rare. It happened in few cases. This is the final view after hemostasis of one of the cases we had. As you can see at the end, we have the cochlear nerve and facial nerve and all the nerves and the petrosal vein still functioning. different approach we have for the, not different, but I mean, different scheme we use in large tumors, large vestibular schwannomas at first. After cutting the capsule, we used to generously remove inside the tumor all the mass, I mean, all the parenchymal part of the tumor with a generous tumor coring and the bulking. And we use for this sonopet, laser, and several micro instruments, of course. The sonopet setting is quite important in order to avoid the possible irritation of nerves, and so this is the setting we use. The power is 0.5% of the possible total power. Low suction and irrigation criteria. This is a recent article we published on our consecutive 60 cases of grade 4 vestibular schwannomas with results on neurosurgical review. In summary, the function of facial nerve of large removal, of removal of large vestibular schwannomas depends mostly from two factors: the adherence of capsule to the nerves and the vascularity of tumor. So we had adherences, tight adherences in more than 60% of cases of large tumors. And in more than half of cases, the vascularization was very high. So hypervascular tumors. And Professor Kono wrote a very nice article on hypervascular post-grade 4 schwannomas some years ago. In our series, facial nerve was anatomically preserved in about 95% of cases, especially in the last 5 years. But we have HP1 and HP2 in about 72% of cases at 6 months follow-up, with some improving after at 1 year, but no more than 75% of HP1/2 with these large tumors. And these were the mean end surgery stimulation of 0.26 milliampere for HB1 and 0.33 milliampere for HB2. After the total removal of tumor, the most important step is to close without possibility of CSF leak. It is a very challenging step, this, because in the past we used many, several, I mean, substitute, several glue, several things, but the best we published was the putting the graft. We take it, harvested at the beginning of the surgery, and sutured it with taking account that the most important thing is put this graft under the level of the dura. Only in this way, like an umbrella, like an hourglass shape, we can suture in the best way in order that to avoid that the CSF coming from the deepness can pass through this graft. And this, starting from this experience, we had surely less cases. So this now is very seldom that we can have problems with the wound or problems with CSF leaks. Very useful for this was also the application at the end of the suture of this product, the Tacocil, that we use normally when we have some bleeding, venous bleeding, and what also efficient at the end of the suturing of the graft above the dura part. Some nuances of facial and cochlear nerve preservation. As you told me before, we use always nimbus mono or bipolar stimulation with continuous EMG recording. And the cochlear nerve was monitored always in cases of socially useful hearing before the operation with ABR. In all cases, we use high dose of steroids in the postoperative period in order to maintain the macrovascular supply. And since some years, we use also nemotop. I will show you later the study of the CNS. This is a case when we could not remove totally the tumor because it was very adherent to the brainstem, especially in the entry point of the facial nerve. So for facial nerve preservation, sometimes, in my opinion, in case of tight adhesions, or better to leave a millimeter residue of capsule and check it with serial MRI. So total removal is always our aim, but in some selected cases we cannot do it. So better to don't insist, especially if the intraoperative stimulation starts to inform you that the nerve is distressed. This is the system we use for the monitoring the function of the cochlear nerve intraoperatively in cases of attempt of hearing preservation. This new system is a carrot C seal at the air, and this was used at the beginning for pediatric othologists in order to obtain answers from the possible deaf newborns. Then we mutuate this experience to intraoperative experience, and we realize that it's very fast than the classic click normally used in the majority of cases, and very affordable. So we published our first experience 6 years ago, and now we use routinely in the surgeries with attempt of hearing preservation. In all cases, since many years, we use the intracisterna diluted papaverine. So, you know, it's the hydrochloride. This intracisterna diluted use prevent probably, as you know, from the vasospasm or aneurysm, prevent the spasm of the microvessels and probably improve its vascularization. We had around less than 100 cases in 60 months, so we wait a little bit to increase our experience in order to publish. In these 5 years, we had good results, probably not only for the papaverine, of course, also for the learning curve. This is very probably. But we had good results, a little bit better than before, and we have to now to approach this in a statistical way and understand if it is a true improvement or not. We use also intracisterna diluted steroids, so every cleaning we do with the water is water with steroids. And as I told you before, steroids, high doses of steroids, intravenous steroids for 10 or 15 days. About the laser, we have to use movies and some talks. Anyway, it seems to be safe if you can use. So you need, of course, a learning curve. We had a learning curve first with large meningiomas, other tumors, in order to understand how is the limit of this tool. Then, when you can use in the right way, it facilitates the resection, especially in difficult cases with the high vascularization, large heart tumor, and we have published some experience on this topic. As told you a little bit before, we use this nimodipine, and immediately after the recommendation of the CNS, so there is a level 3 study that justified the perioperative treatment with nimodipine. We have 68 cases with 64 HB1, HB2 at 60 months. This is, of course, a small series. We wait a little more for obtaining large cases and then understand also here the statistically point of view the real effectiveness of nimodipine in these cases. In the past, some studies tried to understand if some drugs like COX-2 inhibitor or the progesterone-like, glucocorticoid-like drugs could block the growth of acoustic neuromas. But at the end of the story, it seems to be that no one of these is very effective. The COX-2 inhibitor was used also in our series in some few selected recurrent cases, less than 10 cases, without any improvement. And they reoperated all these cases. And also progesterone and other similar hormones probably affect the metabolic activity, but it's not clear if are used to block the growth of the tumor. Probably not. Oh, sorry. Oh, dipende dalla condivisione. Okay. On the other side, extremely usable seems to be the MRI with DTI software that try to localize the possible position of facial nerve. There are several studies, some coming from China and some coming from India. Very good studies. We try to start now with our center to do the same. Anyway, it's not clear if this technique is 100% affordable. You know, exactly, this is the arm of the study we would like to implement. I mean, exactly the blind experience of surgeon in location of the facial nerve, and after that compare with the possible position according to the diffusion tensor imaging technology. We will see. We just started really a few months ago, so we have not any data for the moment. So in conclusion, vestibular schwannoma usually, in our opinion, requires surgery. So White scan is possible in small tumor in old and deaf patients, and only in patients in bad condition, without hearing, and small tumors, we suggest sometimes radiotherapy. This is not a war against radiotherapy, of course, understand. But I think, honestly, that in the right centers, vestibular schwannoma requires surgery and needs surgery. Total removal, preserving facial nerve is usually possible. I mean, the size of tumor, as we told before, is fundamental. In large tumor is a little bit more challenging, especially if it is hypervascular or very adherent. But normally we can do a very good job also in big tumors. In selected cases, with tumor less than 2 centimeters with socially usable hearing before surgery, we can try to preserve. And in 2 out of 3 cases, we can succeed. So at the end, I again stress the concept that the microsurgery can cure vestibular schwannomas. Only microsurgery can cure vestibular schwannomas. And this is the first page of a book recently published with my mentor, Taka Fukushima, and another guy, my resident. And I was very proud to have this talk in this meeting. Very privileged for me to have this kind of audience, a very high level of audience, outstanding people. So thanks again for the opportunity you gave me, and thanks again to all the participants for having the passion to hear my presentation. And sorry for some problems during the presentation, but this Zoom technology, I know since very few weeks. So sorry if something happened in the presentation. Thanks a lot.
So thank you, Luciano, very much for your nice presentation. Now we have ample time for discussion here. So there are certainly very experienced acoustic neurinoma surgeons who might tell their opinions maybe I give the word first to Atul Goel.
Yeah, thank
Atul?
you. Yeah, thank you, Yuha. You see, acoustic neurinoma surgery is a difficult surgery, as Yuha has mentioned, because the facial nerve is in problem, and if the facial nerve is damaged, the identity of the person is damaged, and the person will never be happy in his own life. And if he tries to be happy and if he tries to smile, others will not like it, because the face and the whole operation, the entire neurosurgery of acoustic tumor is centered on how to preserve the facial nerve. Whether you want to do monitoring, whether you want to remove the drill, the lateral wall of the internal auditory meatus, how you dissect the capsule, whether you have to leave the tumor behind, and how much tumor has to be left behind, whether you can remove the tumor totally and preserve the facial nerve, whether you want to be conservative, whether you want to be aggressive, whether you want to be safe and very safe, because it all depends on how safe we are and how sure we are that the life of the patient will depend. So, Luciano, my question to you is, I have got a very big experience of acoustic tumor surgery and a big experience and experience of very big tumors, like you are saying. Now, my conclusion after my experience is, in large tumors more than 3 or 4 centimeters, you can never remove the tumor completely and save the facial nerve. You have to leave a small bit of tumor on the facial nerve if you want to save the function of the facial nerve in large or huge tumors, except in very few situations you can remove it completely. I want to ask you this question, whether you can remove the tumor completely in tumors which are more than 3.5 and 4 centimeters. Please answer this question, Luciano.
Yeah. It's a very nice question, and it's a very important feature. So I agree with you that the total removal in a large, especially if a hypervascular and very adherent tumor, is very difficult. It's very difficult. And in several cases, I tell to the patient, I did a near total removal. I mean, as you told before, I leave some small linear capsule of tumor attached to the facial nerve. This is totally true, totally true. The case I demonstrated before during the presentation is one of probably the 15 or 20% of cases in which I could remove everything, but it's very, very seldom. If the tumor is not very adherent, and this is strange in large tumor, and if the tumor is not very bleeding, and this is also not common, is possible probably. But as you tell, is a less percentage of cases. I totally agree with you. It's likely.
The other thing, Luciano,
I agree.
another thing, Luciano, which you mentioned, which I didn't hear properly. Now, because to preserve the facial nerve, you leave a small tumor behind, you know it, and that may not be big residue. There may be a small capsule, very thin capsule. It is not that you leave half the tumor behind and you are conservative, you leave 50% of tumor behind. That is not the issue. If you leave a small capsule on the facial nerve, I want to ask you, whether you do radiosurgery for this residue, you know that you have left the tumor behind. So what is your strategy on where you have left some tumor behind? You know it. And even post-operative MRI is showing some residue. What is your strategy on such residue?
This is, again, a very good question, because also patients tell me the same question. So what I have to do now with this small residue of tumor you decided to leave after this huge tumor removed? And at the beginning, I tried to send someone immediately after surgery to radiotherapy, but they had some problems, facial nerve paralysis or disturbances, I mean, sometimes symptoms that they had not before. So at the moment, since many years now, I prefer to watch and with several CT scans, MRI during 6 months, after 6 months, 1 year. So we do many controls. And then if tumor is growing again, that this was very seldomly in my experience. But in the cases that we had some recurrences, I mean, some regrowth, not recurrence, regrowth of tumor, I prefer, if possible, to go back with surgery. No radiotherapy. Of course, if the condition of patient is very bad, in the meantime, he had cardiopathy or so the other failure, and probably is not the best indicator, old man, old woman, so it's not the best condition for reoperate, probably I send them to the radiotherapy. But at first, I prefer, in the rare case that we have regrowth, to operate again.
Another question, Luciano. I want to know from your experience, what do you think is the vascularity? From where are the blood vessels feeding the tumor? What is your impression?
This is a challenging situation. Professor Kono had some years ago, published some years ago a very good paper on this possible vascularization coming usually for the vertebro-basilar system, but sometimes from external carotid too. And this is also my small experience. I mean, I have not thousands and thousands of cases, but my experience is that in a majority of cases, the blood comes from the vertebro-basilar feeders. But in some cases, especially in large tumors, some vessels coming from the external carotid artery by the dura or by the bone, they can contribute to the vascularization of tumor. This is my experience. I don't know your experience. Probably same. I don't know. I hope.
No, same, exactly the same. My feeling is, you see, the vascularization is on the inferior, on the, if you are doing from the lower pole, under surface, there is always a vessel which comes from the vertebro-basilar system and goes and feeds the tumor. Apart from the dura and external carotid supply in the dura and around the internal auditory meatus, there is almost always a small vessel coming from the vertebro-basilar system, almost always. This is my observation.
Agree.
Professor Gono, you want to
Hi.
say something?
Yes. So my experience is same impression. So from external carotid system, so feeds the around the internal auditory canal, around the auditory canal, but inside, mid side and the caudal side was fed from the vertebro-basilar system. My impression. And so, Luciano, thank you for your educational lecture, and I enjoyed it. So I'll talk about the dorsal displacement of the facial nerve. You didn't experience so much, but from our experience, 4 or 5% of our patients show the dorsal displacement of the facial nerve, partially or completely. Today's case is the same. So 7th and 8th cranium was completely dorsal displacement. But I took the tumor 70%. So using many kinds of technique or something. So it's a very problematic condition for us. So as same as hypervascular tumor and the dorsal displacement of the facial nerve. So in the future, so you will have to see the same condition, complete dorsal displacement of the facial nerve. So you have to take the tumor so from rostrally or caudally or something. So
I hope not too many. I hope not too many.
Really, you are lucky.
Probably.
Are there any differences in the surgical techniques? There are very experienced neurosurgeons in acoustic neurinomas. Are there any differences in taking the tumor out, or this is a rather standard technique now with the present times microneurosurgery? This is my question. Please answer. Are there any differences?
To answer, yes.
Surgical techniques. We hear last time in many cases we heard from Professor Durgoel many different opinions and techniques. So how is your opinion? How is your technique to take these tumors out?
You ask to me or to Professor Goel?
Professor Gono, Atul, and
I see the.
if there's someone who has large experience, please tell and ask now. About
I have a feeling, you know, how you remove the tumor, how you debulk the tumor, and how you dissect the tumor capsule from the facial nerve, how you use two hands, and how much you coagulate inside the tumor, outside the tumor, around the internal auditory meatus. You see, if you ask me my technique, in my technique, the coagulation inside the tumor is absolutely minimum, and coagulation outside the tumor is essentially very little. So you can do a rather quick debulking if you are strategic. You debulk the tumor, and my feeling is coagulation inside the tumor is waste of time, and coagulation outside the tumor is a technical mistake, except at one point in the inferior dome of the tumor. So basically, you can, the whole neurosurgery, you see, everybody is interested in acoustic tumor surgery, and everybody has experience in acoustic tumor. How you debulk the tumor,
not me.
how you, how you reduce the tumor bulk, how you dissect the capsule, how you save the facial nerve, how you save the eighth nerve are beautiful stories of your life. And you know, if you have not saved the facial nerve, you patient will not be happy all his life, and you yourself will not be happy. Means it is such a challenge, it is such a huge challenge to save the face. And I think there are very few neurosurgeons. Ask me, I can very clearly say there are very few neurosurgeons in the world who can remove the tumor completely and save the facial nerve function. That is my impression. And I want Kono to answer this question, and I want Luciano to answer this question. You think there are hundreds of neurosurgeons in the world who can remove the tumor completely and save the facial nerve? I have a feeling very few. What do you think?
May I answer?
Yes, Luciano, please.
Again, totally right. Again, once again, you know that recently there are many articles that are encouraging the neurosurgeon to remove just a part of tumor and then send patient to radiotherapy. This is the reason, because as you told before, the risk of facial pulse is very high. So this could be a little bit controversial. If I decide to operate, especially a young patient, I decide as a first option to remove as much as possible. I cannot believe in my mind to leave 30%, 20% of tumor and then send him to radiotherapy. For them, you know, on my point of view, the patient risks a lot with the surgery. So in this situation, you have to do the best you can do. Of course, as we told before, it's possible to leave some remnants, some thin residual of capsule attached to the facial nerve, especially in giant tumor. This is normal. But in this case, we can have other strategies, not radiotherapy immediately. In the future, we can decide. But I would like just to add a little thing to the discussion we had before, that when in the few cases, this It's not, of course, scientifically correct, but in the few cases that I had to reoperate for the small remnants I left on the facial nerve during the first surgery, the second surgery, the removal of this part of tumor from the facial nerve was surprisingly easier to the first, in comparison to the first surgery. I don't know the explanation of this, but I'm sorry, only few cases, but in 10 cases probably I did this. The possibility to separate, to dissect completely the capsule to the facial nerve was much easier. I don't know your experience.
Can I talk? Can I talk?
Professor Kono? Yeah, please.
Surgical technique is very important, of course, but I would like to emphasize the importance of using the continuous facial nerve monitoring, not the free running EMG, continuous stimulation of the root zone of the facial nerve. So under the continuous facial nerve monitoring, we can take the tumor very easy. So not easily, but so if the monitoring changes, we can stop the procedures. So that's why. I want to emphasize the importance of the continuous facial nerve monitoring. So I recommend using continuous facial nerve, not free running EMG, continuous stimulation. So using a ball point.
Dr. Professor Kono, you have been proponent of continuous facial nerve monitoring for a long time, and I have heard your lectures on facial nerve monitoring for a long time. I want to ask you a question on continuous. Why you need continuous facial nerve monitoring? What is the reason? Why you want?
Why do you think so?
No, you can see the facial nerve. You can see on the dome of. So why you need monitoring?
But we can't see the function of the facial nerve. Just seeing the facial nerve, we can't see the function of the facial nerve. So electrophysiological monitoring finding is the most reliable mark for us. You have to know that, I think.
No, I understand.
Why you don't understand?
This is your technique. I understand, to keep the monitor inside, and it keeps on interfering in your field. You see what my strategy is. You see, I see the facial nerve, and I around a little bit here and there, I'm very careful. I just don't dissect the nerve from the capsule. I don't try to tease the nerve. You see, I don't try to tease the nerve off the capsule. That is my technique in acoustic tumor. Like, there is no need to tease. So if you're not teasing the tumor from the capsule, and unless it is, sometimes it comes out rather easily. But if you're leaving the capsule and you are seeing the nerve, you can intermittently monitor the facial nerve. Why continuous monitoring?
Continuous is fundamentally safe for us. So we need the current condition of the information of the current function of the facial nerve. Always. That's true. Believe me. But you are not a standard surgeon, okay? Like a god, okay? You are quite different, okay?
Thank you, Professor Kono.
For ordinary neurosurgeons need continuous facial nerve monitoring.
No, Professor Kono, you are very well known in this, and you are very experienced in acoustic tumor. When you say we have to listen to you and we have to follow you, no question about it. But sometimes many parts of the world, that kind of continuous, like in India, I don't have the thin monitor that you have. It is, you are blessed. You are working in world's most technologically advanced country. My, situation you have seen, I do sometimes 4 or 5 acoustics a day. And if I keep a continuous monitoring all the time, I may, it takes time also. You have to go slowly, and time and all those things also are issue when you are doing
I don't
this.
think so.
No?
I don't think so.
Okay.
Okay.
So you are experienced neurosurgeon doing acoustic neuronoma surgery. May I ask you a frank question? What is your worst experience of acoustic neuronoma surgery? What remains in your mind? And I have been writing my memory, so many that kind of terrible things not related to acoustic neuronomas, because I have operated only maybe 50 cases, because in Helsinki there was a own team who was doing them. But what is the worst memories of acoustic neuronoma surgery? Deaths or something else? Can you tell?
Let Luciano, please.
Yeah. I remember very well all the patients that had facial palsy grade 4. I remember all these persons. By fortune are not so many, but I remember one by one. And this is, for me, is the worst result. By fortune, I don't have any death. This is very important, because you have to guarantee at first the life of a patient. I don't have this, but all patients that had some facial palsy for the life are all in my mind. This is my worst experience with this. Very seldomly transient dysphagia, very seldomly transient diplopia, but never permanent deficits. The only permanent deficits that I remember is probably 10 cases or a little bit more that have a permanent grade 4 facial nerve palsy. They're terrible situation. I remember everyone by name.
Luciano, I want to ask you one question. Have you ever got lower cranial nerve weakness after surgery? Say yes or no.
Please, can you repeat?
Have you got lower cranial nerve weakness after surgery? Lower cranial,
No.
dysphagia, hoarseness.
I told you, I had some transient dysphagia for very huge 5 centimeters, 4.5 or 5 centimeters or more, transient dysphagia, not permanent dysphagia.
I agree with you. You see, lower cranial nerve deficit, if it happens in acoustic tumor surgery, it is a very if it happens once in 200 cases, okay. But if it is happening more than once, it is an absolute. One should stop doing acoustic tumor surgery if he gets lower cranial nerve palsy. I want to ask you, Luciano. Luciano, I want to ask you a question. How do you deal with the lower cranial nerve during your surgery? How you dissect them? What is your surgical strategy? Do you deal with them early in the operation? Do you deal with them later in the operation? What is your surgical strategy?
First, we monitor also the cranial nerve function with the anesthesia. We have anesthesia tube.
John?
John, can you help? Is it Spanish? Okay, who was speaking now? About the lower cranial nerve palsy, because this might be a fatal situation if you are not dealing with them properly. This is lower cranial nerves are the most important cranial nerves in relation to life. So what I have done in my case is not related to acoustic neurinomas, but I have done always immediate tracheostomy in these cases.
I was telling that we use this tube with an electrode. So the endotracheal tube has an electrode that is evaluating continuously the function of this of the muscles innervated for the neurocranial nerves. But first of all, that on the technical point of view, this is a monitoring, of course, is useful, but the technique is, in my small experience, is to maintain always the arachnoid plane. Maintaining the arachnoid plane, we always, also in large tumors, we succeed to separate the, to separate the capsule of the tumor from the lower cranial nerves. I don't approach the lower cranial nerve immediately. At first, I debulk as much as possible the tumor, as much as possible. I mean, sometimes it seems to be too much, but I prefer to have a very thin capsule of tumor, and then I go to search the plane, the arachnoidal plane, in between the capsule and trigeminal nerve, but this is of course easier, and in between the capsule of tumor and the ninth and the lower cranial nerves. Only after a very generous debulking I do this in huge tumors. In small tumors, of course, it's much easier. Sometimes there is not connection. Sometimes it's very easy to separate this. The arachnoid plane is fundamental. In my opinion, debulking and arachnoidal plane are the two tricks for saving the lower cranial nerves. I hope you agree.
Yeah, Luciano, another question I want to ask you. You said you have 50% hearing preservation, and you said in your lecture. What is your strategy of dissecting and separating of the eighth nerve? How do you do that?
I follow the indication of my mentor, it's Taka Fukushima, everybody knows. Normally, when we have an acoustic neuroma in a patient without hearing preserved, we started from the lower. I mean, we started from the possible position of the eighth cranial nerve, because we know that this patient lost his hearing, in order to spare as much as possible the facial nerve. When we have this situation, I mean, trying to preserve the hearing, I normally start from the above, I mean, from the seventh position, and going down to the cochlear nerve. I mean, my scheme of dissection is completely the opposite. So when the hearing is lost, I go directly lower in order to find the plane without taking account the possible anatomical preservation of the cochlear nerve if the patient is deaf. But if the patient has good hearing, I start from the facial and I go very slowly in order to prepare the plane and take the plane with the seventh and the eighth cranial nerve, of course. This is my strategy by the teaching of Taka Fukushima.
Professor Yuha.
Yeah. So I was thinking, about you didn't mention the worst complications, worst memories of this surgery. You must certainly have. I remember my grandfather in neurosurgery, Gunnar Björkesten. He was a good surgeon, but he didn't use the microscope in his time because it was before microsurgery. I remember when he died, and I went to his funeral. So there was one older lady with severe facial palsy sitting in the back row, and it looked so sad. So facial palsy is extremely bad complication, of course, but did you have any deaths in these cases? I saw in 70s, I still saw deaths in acoustic neurinoma surgery. So the microneurosurgery has changed so much in these cases. So you are speaking more about facial nerve and then about hearing preservation, not about the deaths. Did you have any deaths in
One
your
thing is,
series?
what you said, Yuha, is about the facial nerve. That is number one. You see, one thing I have learned in my life, never to promise the patient, never to promise the patient that I will certainly save the facial nerve and don't worry, I will be there. We have to be never say, yes, I will save it. Of course, whole operation depends on you, how you save it, but never make the patient overconfident because you can damage the facial nerve. And nobody can say that I will preserve the facial nerve in all tumors and my facial nerve is 90% or 100%. I don't believe in that kind of a story. That is number one. Second thing is about deaths. You see, the second thing before I talk about death, you see, there are many tumors, at least in my own country and in my own practice, where patients come with visual deficit, they come with blindness, they come with blurring of vision. You see, many in Luciano's presentation, I didn't see any patient who has come with blindness and visual deficit. You see, they tolerate the tumor, they till they tolerate the ataxia, they come when they almost blind or they are almost ready to fall. So these kind of tumors, there was a, first thing is to save the life, as you have mentioned in the introduction, that saving of the life and saving of the vision is also one very important indication of surgery. And in that huge tumor, sometimes, of course, death is a very remote possibility, but it is a distinct possibility. And the patient can die. You see, if I have done 1,000 cases, I will be very hesitant to say that at least 3 or 4 or 5 of my patients must have died in my. I have done, to tell you, 1,200 cases. And in 1,200 cases, I will certainly say at least 3 or 4 or 5 or even 6 patients must have died in my series over the last 35 years of my career. And it is very difficult to say, no, no, I have no deaths. It is a distinct possibility. So when you are explaining to the patient about that you can damage, your facial nerve can be damaged. You can never say that I will come in the huge tumors without. You have to keep this option also. But if the patient dies, you have to, you have done a huge mistake and you have left some bleeding behind. Now if you ask me why the patient has died, patient will die if you have not handled the major feeder to the tumor, which comes from the vertebrobasilar artery and comes and supplies on the inferior dome of the tumor. You have to coagulate in that area. And if you have not dealt with that vessel, you can have a post-operative hematoma and you have to re-explore, or even your patient can die. So most important cause of death in acoustic tumor is that you have not handled that feeding vessel. And the other cause of death is many people, including myself, I do acoustic tumor in sitting surgical position. Sitting surgical position is a beautiful position for large tumors. Many senior neurosurgeons in the world, like Sami, for instance, like Ugo Ture was saying, to operate sitting position is a beautiful surgical position. I will say in huge tumors, if you give me lateral position and like Fukushima position, I will not be able to operate on huge acoustic tumors. It is impossible for me to release the CSF to handle the bulging brain in a lateral position. So sitting position is a beautiful position in my estimation. Now, if you are doing sitting position, there are some situations where you can get a venous infarct and venous air embolism and air embolism related death. So that is the other cause of death. One is leaving the feeders, and second is air embolism if you are doing sitting surgical position. So these are the two situations which can be cause of death. But in modern neurosurgery, in a neurosurgery where your vision is so big, even in those situations, I will be very hesitant to say that if I have done so many cases, that is not a single death in my series. I think that is not correct. It is in the same fashion that there are many people who say my facial nerve preservation is 90% or 95%. You know, there are some things that senior neurosurgeons and who have experience will completely understand that this is not a true or correct statement. 100, I say facial nerve in 80%, 90% patient, and my facial nerve dysfunction is 95%. I don't think we should go in these kind of percentages, and these kind of presentations can actually demolish a young neurosurgeon who is going to watch your presentation. So this is my experience, and this is my this is what I have to say.
Okay, we have a question.
So,
Go ahead, Juha.
may I comment? May I?
Yes.
When I was trained in Helsinki in 1970s, so the acoustic neuronoma surgery was these were the cases for professor or chairman. It was called King operation of the king. So how long time do you think it needs to do nowadays level microneurosurgery in these tumors? How long training you need? How many years? How many experience with tumors? When you can begin to do it?
No, acoustic tumor are, you know, every neurosurgeon wants to do acoustic, but
I didn't want to do any of them.
But you are the master of vascular surgery, and
Yeah,
how
but
many?
I didn't want to do them. So no, don't say that everyone wants to do them.
No, you are the king of because you
Without
know
challenging lesions, if you make one first case and you have facial palsy in that, then you are blamed with all the surroundings and society. So it is very difficult to begin. You have to train with someone to see how the good surgery is done. So what is the level you can, after thousands of microsurgical operations, or how many years, what is the level? When did you begin to do acoustic neuronoma surgery? Dr. Kono, Mastronardi, Atul?
Professor Juha.
How long training?
I began to do my acoustic neuroma resection in my 5th year after I'm a neurosurgeon, 5th year. So when I was 29 years old. So actually it's not so difficult in small size acoustic neuroma. So my question for Luciano is, you mentioned that you do some, you also transfer some patient to do the radiotherapy. So what's the threshold size that you think it's not possible for total resection, and you may have some residue, and to preserve the facial nerve, and then after that you may transfer them to the radiotherapy?
Thanks for the question. So at first I answered to Professor Juha Niemi. I had this experience. I mean, I started with my experience in acoustic neuromas about 15 years ago. So my experience started 15 years ago around, and of course, year by year, I like to say that every year I improve a little, and I use new instruments and new technologies and new monitoring. For this question, I have to answer that the main aspect that I consider when I rarely suggest radiotherapy is the age and general condition of patient. Of course, non-enlarged tumors. So I have to admit now a lady of around 80 years old with a grade 4 large tumor. So I don't consider in this lady possible to do radiotherapy. I will do a generous debulking. That's it. But small tumors are considered like COS1 and COS2. So under 2 centimeters, 1.5, 2 centimeters, it's a possible target for radiotherapy. But I always tell to the people that seldomly I send to radiotherapy, please consider that this is not a cure, just to try to stop the growth. And I'm not sure that you will succeed. I have a story, if you have time to understand, of a lady. This is not
We have a lot of time. Yeah.
This is a lady of 56-year-old. I have not now the image, but it's easy to describe. This is a 56-year-old lady that had some strange disturbances around the ear, and she did an MRI last year. She did an MRI and they found a small intracanalicular acoustic schwannoma. She went to several ENTs and neurosurgeons, and everyone told us, wait a little. Someone told her, no.
Latinos are disturbing.
Can you hear me?
Okay, continue.
This lady at the end was forced by someone to do gamma knife. She did gamma knife. She did gamma knife in December 2020. After a few weeks, she started to have dizziness, loss of hearing, totally loss of hearing. She had facial palsy and vertigo and imbalance, severe imbalance. She did again a post-treatment MRI about 5 months later, and the tumor was increased. So I told her, please write everywhere that radiotherapy is not an easy treatment, is a very risky treatment. And you can do it only if you have no other option of surgical option. And so if you have the health to be operate, I mean, to be treated by surgeon, please do it, or wait. She could wait. She could wait a little, do some more MRIs in the ears. Then if growing, probably surgery. But this treatment forced to radiotherapy, and in many countries, in Italy too, they do. It's very bad because it's not a treatment, it's not a curative treatment. So in only few cases with the old patient, general bad conditions, small tumors or small remnants, probably growing, of course, remnants growing, I can suggest time to time the radiotherapy. Otherwise, wait or surgery. This is my point of view. I hope to answer to your question.
Okay, thank you. So I have a question for Atuko. Professor
Yes.
Ko, because you have, I think you have so many huge acoustic neuroma. So what is the biggest size you have ever operated?
No, I have operated a huge size, which was, occupying. I wish I could have shown you. This patient was, you see, it can be huge, it can occupy. The most beautiful thing in large acoustic tumors, I have got one bilateral acoustic tumor where no brainstem was seen and the patient was walking normally. You see, bilateral, no brainstem. So that the way how the brainstem maneuvers and how the plasticity of the brainstem, you cannot see brainstem and the person has no deficit. So over long period of time, they grow, and the brainstem maneuvers and brainstem becomes deformed, but the brainstem is functioning. So it can become very huge. And I wish I could have shown you the size and all, but they can become huge without major deficits, particularly bilateral one. Bilateral ones can become huge. You will be surprised to see these kind of tumors. So surgery for large acoustic and massive acoustic tumor is a difficult operation when you know it.
Yeah.
It is not easy. It is not easy. And to be able to debulk the tumor, dissect the tumor from the cranial nerve, dissect the tumor from the cerebellum, from the brain stem, from the cranial nerves. It is not only technique, it is philosophy. It is how you concentrate on the subject, because even in large tumors there may be no facial weakness. There is no facial weakness in huge tumors. So patient wants face back, patient wants limbs back. So we have to be very philosophical. It is a technique and it is a philosophy, and operating on, as you have said, it is a matter of very great thinking. You need to grow in your subject of neurosurgery. You have to know where to stop. You have to know where it is dangerous. You have to know how much to remove. You have to know how to remove. If you go on coagulating in massive tumors, you will never be able to finish. I know people doing acoustic tumor for 15 hours, 20 hours, and they have removed 20% of tumors. So you have to be aggressive. You know how to debulk the tumor. You have to know how to break the tumor. You have to know how to demolish the tumor and preserve the capsule and preserve the arachnoid. It is a beautiful surgery. I think, this is one of the most beautiful neurosurgery, that if I have to select one surgery which is very passionate, I think I will tell you acoustic tumor is my most passionate and the best I like, because it gives you challenges, it gives you a goal that face should not go. It gives you a beautiful destination. Bin.
So Gore, uh, because in very huge size acoustic neuroma, it's very difficult to preserve the facial nerve. Sometimes the facial nerve was compressed by the tumor, and actually it's extended to a very thin layer. So
Yes, this is
yeah,
a very
so
important question. But
so
the thing is,
I also have a question for Professor Kono. So do you have some experience that in the huge size acoustic neuroma, you couldn't find exactly where the facial nerve is?
Maybe so. I couldn't do the continuous facial nerve monitoring. Only 5 cases. Okay, 5 cases. 5 cases. I couldn't find the root exit zone of the facial nerve. Of course, those were the huge tumor. But from my experience, 1,500 cases, only 5 patients. Okay, very small, very rare.
So go, please continue.
yeah.
What about hydrocephalus? Some patients have hydrocephalus. Are you making a shunt before tumor removal or not?
Let me answer this question which Bin has, and then we talk about hydrocephalus. You see, Bin, I have to answer this question very, very correctly, because I know many young people are also watching this show. And if you ask me, in large tumors or massive tumors, can you see or localize the facial nerve completely on the dome of the tumor? You see, my answer is yes. You can see the facial nerve at the inferior limit of the tumor, in the region of internal auditory canal, you can see. But on the dome of the tumor, it can sometimes be so flattened, it can be like a absolute transparent. And if you try to dissect the facial nerve fibers from the capsule, you will 100% damage it. So you have to have big experience in how to save facial nerve in massive tumors. So my strategy is very clear, and I believe in this, that in tumors which are 3 centimeters, 4 centimeters, more than 4 centimeters, you have to leave a large shell of the tumor and don't even try to tease the tumor. And this is in almost, in large tumors, in almost 100% of cases, I don't try to dissect the tumor capsule from the facial nerve, because my experience is if you do it, you damage it. So that is my answer. And don't do
Okay.
it because face is so important. And if you damage, you try your skills, you try your dissection, you damage the face, the patient is finished for his life. Don't do it. Don't even try it. This is my answer. Over experience, of course, and you asked me since when you are doing acoustic tumor surgery. Acoustic tumor surgery, you see, what happened in my life is I became chairman 25 years ago when I was less than 37 years of age. So it very early in my career, I had started doing acoustic, and my hospital is a free hospital. So my experiences become big, and that is the advantage. Other question, you asked me about hydrocephalus and shunts. I will answer that question very positively. The answer is never, never shunt. No matter how big the tumor is, no matter how big the hydrocephalus is, never shunt. This is my answer. Because even in massive tumors, you can open the cisterna magna very early in the stage, and you open the cisterna magna, the entire thing relaxes. And it certainly, and if you have done a shunt, if I get sometimes patient where shunt is already done, and that makes my operation difficult, and dissection from the facial nerve, dissection from the brainstem difficult, because the tumor gets sucked in and it gets stuck to the brainstem and to the other structures. And I will never recommend shunt before operation, never.
Also, about the communicating hydrocephalus would be gone after nearly total removal of the tumor. So, Goel said about the occlusive hydrocephalus, but also communicating hydrocephalus would be improved after surgery. My policy.
I have a question to Luciano. Why are you calling this position Fukushima? He's certainly a great surgeon, but this is old. Parkbench position was used also already by my teacher, Dr. Drake. He called it Parkbench position. Why this Fukushima position? Is there something special in that? This position. It looks exactly the same. I learned from Dr. Drake.
It's a little, yeah.
What are the differences? I'm doing that exactly the same. If you look on my videos in the Helsinki 1001 videos, it is exactly the same position.
In the truth, the lateral position that I use, that Fukushima taught me, is a little bit different because the arm of the patient, the arm below, is not outside the bed, but it's in the bed. And an axillary.
But this is the same Dr. Drake was doing. So we should call it Drake Fukushima position. Yeah. Just to, because Drake was using it already in 1950s, this position. So Fukushima is a little bit younger.
Yeah, he's younger, a little bit younger. Anyway, also the positioning probably of the head is a little bit different, and the body.
No.
Is close.
Look at my videos in internet. So it shows exactly the same position. So, but this is a small detail. It is not important. It's not important whose name is there, but of course you give credit to your teacher. Fukushima is certainly a great neurosurgeon, but I was just thinking why it is called Fukushima position. This is a regular old position.
Sure. Probably I call this because
Parkbench position. Parkbench position was the name. Because the drunken people were lying in the parkbench in this position. So this was called parkbench position by Dr. Drake for his posterior fossa aneurysms.
Same position was called as Concord. position by Japanese Professor Kobayashi. Concord, like it is lateral, like flying up. Concord
But
position.
the head position is totally different than Concord position, I think.
Okay, okay.
Okay, we have
Okay,
we have a question from Jorge Salazar, a neurosurgeon from Mexico. Is it if a tumor for Dr. Mastronardi, if a tumor invades the internal acoustic meatus, do you perform drilling first or after you have removed some tumor outside the canal?
Thanks for the question. If the tumor is small, I mean, cos 1 or cos 2, I start immediately from the canal, opening the canal. If the tumor is large, I prefer to debulk at first as much as possible the tumor in the CP angle, and I open after that the internal auditory canal. This is my strategy that I normally use to do this.
Thank you.
There was in Helsinki, it was a very special cooperation. So the ENT surgeons were opening the acoustic porus. So I did in my few cases always myself. But how are you doing? Do you need ENT surgeon to open the acoustic porus? I found it always a little bit odd.
No, we do by ourselves. In the rare case that we need to do the translab, I do very seldomly, but I do also the translab by myself. So I use very seldomly translab. But the opening of internal auditory canal, we do always by ourselves.
Dr. Kono, Atul?
Yeah, of course. No need for ENT. No need. ENT will remove the whole, for mastectomy or translabyrinthine, okay. Translabyrinthine approach is not an approach for acoustic tumor, no matter what the size is. And if somebody is, many ENT people like to do translabyrinthine for acoustic. There are some, but this is absolutely unnecessary. Retrosigmoid, beautiful, open the cisterna magna, beautiful, identify the tumor, retract the brain and remove the tumor. No need to remove the mastoid, hearing. You can preserve the hearing. Why you want to damage the hearing before you have started the operation? So translabyrinthine is not an operation for acoustic tumor.
I totally agree. Are there some other questions from audience? For Luciano, Professor Kono, Professor Adolfoel. Reda, you have some questions, comments?
Yeah, Verdab is usually pretty active. Verdab, are you there?
She's sleeping.
Okay, she may have stepped away.
Okay, are there any more comments or questions? So if not, that was a very good lecture and then a very good discussion on many points of acoustic neurinoma surgery. So I'm not specialist in that. I could only ask several questions, but certainly those specialists are giving extremely good answers for these rather common tumors, which Professor Atu Goel is saying that everybody wants to operate on. Of course, the price might be high if you cause a facial palsy for a young patient or even older patient, then you damage his or her life totally. So this will remember always in your mind. And like Luciano said, those cases with facial palsy, he remembers also them by their names. So this is a big burden. So this is difficult surgery. So if you fail, the price is high, and who is paying, the patient is paying for so many years in his or her life. I think we have dealt most of the things here.
Okay.
So Thank you very much for good lecture, nice discussion, and we continue next Friday then.
Okay, very good. Thanks, Juha, and thank you very much, Luciano. We look forward to someday meeting you in the Eternal City.
Yeah, Luciano, today we have a 1,300 audience from the Chinese WeChat channel.
That's
Yeah.
great. That's great. Thank you. Thank you.
Thank
Ben,
you for your thank you for your
Second.
presentation. Yeah.
This is good number, yeah.
Yeah,
Great number.
thank you, Takayashi. Also, Juha, do we have a topic yet for next week, or is it open?
Let's discuss. I'm waiting for the lecturer.
Okay.
So
Okay, very good. Thanks
have
everybody
good
for.
network to like.
Okay, we'll.
So we will. I will inform you.
Okay, very good. Okay, we hope to see you,
Okay,
everybody.
thank you.
Everybody
very
next
much.
next Friday. Thank you.
Thank you,
Okay.
Luciano.